Hello and welcome to my poster. My name is Victoria Gonzalez and I am actually a doctoral candidate in the Applied Clinical Research PhD program in the School of Health Professions at UT Southwestern Medical Center in Dallas, where I also attended PA school. I am defending my dissertation in about 6 weeks under the mentorship of Dr. Benjamin Greenberg, Vice Chair of Translational Research for the Department of Neurology. My research focuses on environmental factors in multiple sclerosis, and this poster will present a small portion of my work thus far. The title of this presentation is Dietary Habits and Childhood Trauma in Pediatric Myelin Oligodendrocyte Glycoprotein Antibody-associated disease, also known as MOGAD, and Neuromyelitis Optica spectrum disorder, also known as NMOSD. Try saying that 5 times fast. So let's explore this together. For the sake of efficiency, I'm going to summarize the abstract and introduction together. For those who are not familiar with these conditions, MOGAD and NMOSD are two rare autoimmune demyelinating diseases affecting the central nervous system. You may have heard of the more common disease of this group, multiple sclerosis, often abbreviated as MS. And similar to MS, these two conditions manifest acutely as a number of neurological symptoms, including vision loss, motor weakness, sensation changes, bowel and bladder issues, gait difficulties, and cognitive issues. Now, these symptoms undoubtedly have considerable impacts on adult patients, but I want you to imagine the profound interruptions these would cause in the life of a child. While there are treatments for acute flares and medications for chronic management, which we call disease-modifying therapies, there are no cures. For this reason, it is essential that we explore etiological factors to target and potentially prevent disease onset. Some of these factors have been explored, including genetics and infectious exposures. Others, including environmental and social factors such as diet and childhood trauma, have yet to be studied. Studies of diet in these diseases are extremely limited, meaning only about a handful of publications on the topic. Similarly, studies of childhood trauma are essentially non-existent. Something to consider is that even though these conditions have similar pathologies, there may still be differences in the role of these factors amongst them. This was demonstrated in a recent meta-analysis of 5 immune-mediated inflammatory disorders, which found that 4 of these conditions, including MS, were associated with the history of childhood adversity, but systemic lupus erythematosus was not. For this reason, it is important to acknowledge that even though these conditions are relatively rare, they still deserve to be explored with the same meticulousness that we explore other diseases. This being said, the aim of this investigation, which is part of a larger study we are conducting, was to explore differences between diet and childhood trauma before onset in pediatric NMOSD and MOGAD using validated self-report measures. The two-tailed hypothesis was that significant differences exist between scores on these measures. This brings us to the materials and methods of this study. Our participants were adults and adolescents recruited from the MS and Neuroimmunology Clinic at UT Southwestern, where I work, and the Conquer Clinic at our partner institution, Children's Medical Center, Dallas. Inclusion criteria for this portion of the study were age 12 years or older, having a documented diagnosis of either pediatric NMOSD or MOGAD, specifically between the ages of 10 and 17, and ability to read text in English. I approached eligible patients after their clinic visits, and if interested, I consented and enrolled them in the study and administered a battery of questionnaires on a touchscreen tablet via the REDCap Secure web platform. Patients were instructed to answer the questions referencing the time period before disease onset to the best of their ability. Of note, this study was approved by the Institutional Review Board at UT Southwestern and adhered to state policies on reporting suspected child maltreatment. There are 3 surveys we'll focus on here. The first is a simple demographic survey to obtain patient characteristics. Information was verified using the electronic medical record when available. The second was the Healthy Eating Assessment published by Paxton and colleagues, which is a 10-item survey of dietary patterns using Likert-type scales with possible scores from 10 to 50, with higher scores indicating healthier eating habits. These scores can be divided into 4 health benefit zones, ranging from needs improvement to excellent. The third instrument was the Adverse Childhood Experiences Questionnaire, published by Felitti and his team, which is a very widely used 10-item dichotomous questionnaire on childhood abuse and neglect. Scores can range from 0 to 10, with higher scores indicating more reported experiences of adversity. Moving on to the results section, data from our sample consisting of 11 pediatric onset NMOSD patients and 15 pediatric onset MOGAD patients was analyzed using SAS statistical software. Using the Shapiro-Wilk test, it was concluded that a portion of the data was not normally distributed. Therefore, non-parametric Mann-Whitney U tests were conducted. The significance level was set as 0.05. Table 1 shows participant characteristics. The average current age was 19 years old for the NMOSD group and 15 years old for the MOGAD group. Average age at onset was 12 years for the NMOSD group and 13 years old for the MOGAD group. They did also differ in distributions of male and female patients. However, this does accurately reflect the distributions in both general disease populations. Specifically, there is evidence that NMOSD is more prevalent in females and that MOGAD has an approximately equal male-to-female ratio. Racial disparities of the diseases were also accurately reflected in the samples. Something I do want to take a short detour to touch on is how rare these diseases truly are and how this can affect sample size. So the incidence of pediatric NMOSD is about 0.06 to 0.22 per 100,000 children, and for pediatric MOGAD is about 0.31 per 100,000 children. To put this into perspective, there are about 400,000 children total in the collection of cities that make up the Rio Grande Valley where this current conference is being held. This means that there would be approximately one child with MOGAD in the entire region, and technically less than one, but we'll round up to one, child with NMOSD as well. So the fact that we were able to include 11 and 15 participants respectively with the additional restrictions of current age and age at onset is pretty significant. Anyways, I digress. Tables 2 and 3 show the ranges of questionnaire by scores and by group. On the healthy eating assessment, all patients fell into the central 2 zones, interestingly, with none in either the needs improvement or excellent categories. On the adverse childhood questionnaire, you can see that most patients were on the lower end of the scale, but interestingly here, MOGAD had the patients with the highest scores of 5 and 6, while NMOSD did not have either of these. Table 4 shows the median total scores on each questionnaire. We see here that based on our p-values, we cannot reject the null hypothesis, that a difference does not exist between the scores for the groups. So in the end, our hypothesis was not supported, which could possibly be due to a few limitations. One being, of course, sample size, which could be remedied by expanding the study to other medical centers or continuing to collect data over time. Second, the sample of patients does come from an academic medical center in a more socioeconomically advantaged part of the community, and including more patients could yield different results. Thirdly, as with all retrospective self-report studies, we cannot completely rule out recall bias in patients' answers, especially with more sensitive topics. This leads us to some fascinating possible future directions for this work. It would be intuitive to look at detailed comparisons of subcategories of these factors, such as specific dietary components or specific types of adversity. Additionally, as mentioned earlier, this is just a small portion of the larger study we're conducting in demyelinating neurological diseases. We also plan to examine possible correlations between these factors and others, and hopefully examine the relationship between these factors and disease outcomes. The final thought I want to leave you with is, what would obtaining this kind of information in the patient population you work with look like? I personally believe that knowledge regarding these socio-environmental factors not only helps us fill gaps as clinicians to improve our abilities to diagnose, possibly prevent disease, but can also help improve well-rounded care for patients who may need resources and assistance outside of the diagnosis code that we assign them in the medical record. In closing, thank you for your time and attention. Thank you to TSAHP for this opportunity. And as a proud alumna of UTRGV, V's up and have a wonderful day.